Welcome to Clinical Medicine 2. In this particular presentation, we'll describe lumbar disorders, including their clinical presentation and evaluation and management. Before I begin, I'd like to take a moment and acknowledge my colleague, Dr. Michael Brown from University at Buffalo, who was instrumental in the development of this presentation. The objectives for this presentation include formulating and implementing a physical therapy plan for a patient with a lumbar disorder using the treatment-based classification scheme presented, and then describe the clinical presentation and evidence-based physical therapy intervention for individuals with various lumbar pathologies. For this presentation, we'll discuss several different clinical conditions, and we'll try and talk to how these patients may fit our low back pain treatment-based classification scheme. So if you haven't reviewed that paper by Julie Fritz and her colleagues, I would recommend doing that before this presentation. So we will talk about the low back pain treatment-based classification scheme. And then the next few slides, we'll talk about two of the more important clinical practice guidelines that deal with the management of patients with low back pain. The first is through the orthopedic section of the American Physical Therapy Association. The second is through the American College of Physicians. And so it's important to know how those guidelines fit with what we're trying to accomplish with our patients. One of your references for this particular week is going to be the clinical practice guidelines for low back pain that has been put out by the orthopedic section of the American Physical Therapy Association. And so let's just speak to these guidelines just for a minute before moving forward with the content for the lecture. As we've done with other regions of the body that we've used these clinical practice guidelines, I recommend that you do a close read of these first 2 to 3 pages where these are the summary recommendations, and then you work through the rest of the guideline as necessary to get more detail for the area that you're interested in. In this particular case today, we're talking about some different clinical conditions related to lumbar spine, and we'll talk about management strategies for those. And in the bottom right-hand corner here, we talk about 2 interventions here: manual therapy and then trunk coordination, strengthening, and endurance exercises. And both of these are going to be highly recommended based upon strong evidence. And so with respect to manual therapy, we're going to use manual therapy if we think about our treatment-based classification scheme for those individuals who meet the clinical prediction rule. And we're going to use that as our primary mode of intervention. For some individuals, though, let's say maybe we're dealing with central canal stenosis, or even someone who has a herniated disc with radicular type symptoms down the leg, it may not be, manual therapy may not be our primary management strategy. We may use other aspects of the treatment-based classification scheme, but we're going to note that there are some impairments, and we're going to likely use manual therapy to address those mobility deficits that we see. It also mentions that we can use thrust and non-thrust techniques. We'll briefly introduce thrust in this particular course at the end of this week. We'll show you a couple of techniques that we'll teach you later on down the road. It's important that you know the techniques that have been used for the clinical prediction rule. We're using non-thrust techniques in this particular case. It's important to know that those have benefit as well. And it's important to note that we're not only dealing with the lumbar spine here, but we're also dealing with the hip. With respect to strengthening exercises, endurance exercises, and trunk coordination exercises, those are all going to be recommended. And many of our exercises, especially some of our stabilization exercises, will fit in there as well. We've already talked about that type of a training program, and we'll reiterate that more as we go through this lecture today. Other interventions that we've discussed previously have related to specific exercise in our treatment-based classification scheme. That would deal with centralization and directional preference type activities, and those are recommended by the guidelines based upon strong evidence. For some patients, especially those who are older with chronic low back pain, we may actually employ flexion type exercises as well for those folks, and that's recommended, but it's based upon some weaker evidence. With respect to interventions as well, We will talk about a group that hasn't necessarily been mentioned by the treatment-based classification scheme, but it deals with these folks who have lower limb neural tension concerns. And we'll talk about that particular population and who may benefit from a very, very specific intervention. And again, that's recommended, but based upon weak evidence. Traction, we've spoken about a little bit thus far in the course, and it's their recommendation to use it is based upon conflicting evidence. The thought here is that there's likely a subgroup of patients who respond to lumbar traction, and it's probably those individuals who have a positive cross-straight leg raise and who peripheralize with extension. And so these are individuals who have radicular symptoms with those complex signs that we just described who likely benefit from traction. Again, that's based upon conflicting evidence. Patient education and counseling is going to be an important component of our management strategies for all of our patients, and it's going to vary a bit depending upon the pathology that individuals have. Our education is going to focus on things that we should not do and things that we should do. For example, we're going to make sure that we avoid recommending things like bed rest. We want to avoid that. We also want to avoid using detailed pathoanatomic descriptions to help our patients. Sometimes that could do more harm than good. Instead, we're going to focus on helping them understand the concepts of basic anatomy and structural strength inherent in the spine, talk about neuroscience and the belief of pain perception. We'll talk about the prognosis, the favorable prognosis of low back pain. We'll talk about coping strategies that really minimize fear and catastrophizing in patients. We'll talk about the early resumption of normal activities and the importance of improving our activity levels and not being so concerned about pain relief necessarily. And so we'll speak to all those today. We'll talk about it more in our last lecture as well, but those are all going to be important components. And then finally, the use of progressive endurance and fitness type activities. Those are going to be recommended based upon strong evidence. And the rationale for that is that fitness seems to correlate with back pain. These folks who are stronger and more fit are likely going to have a better outcome. We also likely are going to have individuals who have comorbidities like diabetes or potentially cardiovascular disease, and exercise is indicated for those individuals as well, and it'll help those conditions for sure. I'll also provide for you this week in your readings the American College of Physicians Clinical Practice Guidelines, and these guidelines also provide very good information that we can utilize to help with the management of our patients. When we look at the recommendations from the American College of Physicians Guidelines, they dichotomize treatment for patients with acute and subacute low back pain compared to those who have chronic low back pain. And if you look at the differences between the treatments there, you'll see that with acute and subacute low back pain, these are essentially interventions that don't necessarily employ any characteristics that would deal with psychosocial overlay. So for example, their treatments include for acute and subacute low back pain, things like superficial heat, massage, acupuncture, lumbar manipulation. And then if those don't work, they recommend using non-steroidal anti-inflammatory drugs or muscle relaxants. And so that's one approach for individuals with acute and subacute low back pain. But if we look at the individuals with chronic low back pain, their non-drug intervention strategies include things like exercise, but also things like multidisciplinary rehabilitation, mindfulness, Tai Chi, yoga, progressive relaxation, operant therapy, cognitive behavioral therapy, etc. And so these really relate to individuals who may have some psychosocial overlay. These are important activities that really blend that mind-body connection that don't necessarily need to be utilized with folks with acute and subacute low back pain, but certainly with folks who have chronic low back pain, where we need to think about graded activity or graded exposure to different activities. And so these are individuals who may be fearful of some activities. We get them moving and they note that they're doing better, they're not getting worse, and they're being more active. Thrust manipulation is also in this as well, and so that can be something that's used for patients with chronic low back pain as well. And if you look at the third bullet there, they don't recommend They don't recommend drug therapy up front, but if they have to recommend drug therapy, they recommend considering nonsteroidal low anti-inflammatory drugs, and if those don't work, they recommend tramadol and duloxetine. Tramadol is an opioid that appears to not have the addictive qualities of some of the others, and then duloxetine is an antidepressant. Again, we're dealing with folks who have chronic low back pain. We're dealing with psychosocial overlay in many cases, so an antidepressant could potentially help those individuals. This particular talk will discuss the clinical presentation and management of the following conditions: herniated lumbar disc, radiculopathy, adherent nerve root, lumbar stenosis, spondylosis, spondylolysis, and spondylolisthesis. The first pathology we'll speak about will be herniated lumbar discs. When we discussed labral pathology at the hip, we talked about the concern over some of the findings that we see in asymptomatic individuals. And the concern with that is that if we begin to see labral pathology in folks who are asymptomatic, it's hard sometimes to place the pathology that we see in somebody who's coming to us for pain. It's hard to place that pathology in the appropriate context. We see the same concern here with herniated lumbar discs. When we look at asymptomatic subjects and the presence of lumbar herniations and other types of abnormalities, we see about 3 in 4 individuals, or about 75% of individuals, are going to have some type of identifiable abnormality related to the disc or the spinal canal. And we'll see things like mild central canal stenosis, we'll see disc degeneration, we'll see disc bulging, as well as small herniations. If we look at larger herniations, the next one up with respect to at least radiology nomenclature would be a protrusion. About 1 in 4 individuals have that. And then if we look at probably the worst herniation, which would be an extrusion, we see these very rarely, probably in less than 5% of individuals who do not have symptoms. We also don't routinely see sequestered fragments. These would be free floating fragments of disc in the canal. We don't see those. And we don't see frank nerve root compression routinely in asymptomatic individuals. And so these larger disc herniations, like protrusions and extrusions, sequestered disc fragments, and frank nerve root compression, we don't see those in asymptomatics. And so the way I interpret that is, if I'm working with a patient and I review their scans and I look at the report and there's note of protrusions or extrusions, certainly sequestered fragments or major nerve root compression, I think that, in my mind, these are likely disc herniations that could potentially truly matter. And so I'm going to take that into consideration with all of my other clinical examination information. The other interesting finding is that you would think that individuals who have these findings on their MRI scans, you would think that it may be predictive of individuals who develop symptoms down the road. So if we take that 75% population, are those individuals who have those identifiable disc abnormalities, are they at any higher risk down the road of developing symptoms if they're asymptomatic? Now, compared to the 25% who likely have a very, very pristine and clean MRI. And we find that those findings on MRI are not predictive of individuals who develop low back pain. And so you're not going to see scans in your practice of individuals who are asymptomatic. We don't see that. I think what that tells me, though, is that down the road, even individuals who have low back pain, it's very difficult to correlate the pathoanatomy we sometimes see on a scan to the individual symptoms. So I just want you to have that framework as we move forward with the evaluation of individuals with lumbar herniated discs. Several years back, there was a move from the radiology associations to standardize some of the nomenclature on the classification of lumbar disc pathology. And we'll talk about that paper here, where they look to determine if they can come up with a standardized language to classify disc herniations. As I mentioned before, the main concern was over these larger disc herniations, and the reason is that Once again, we don't see these as much as in asymptomatics, and so if these are present on a scan, we need to know about it. And so when we define protrusions and extrusions on the image that you see, the protrusions are going to be on the left, the extrusions are going to be on the right. And we see a sagittal view on the top, and we see an axial view on the bottom, meaning for the sagittal view, the individual is cut in half from side to side, and we're looking at them, let's say, from left to right. And the bottom image is the axial view. They're cut in half from top to bottom. And so we're looking at these from the bottom up in these particular cases. And you'll notice that the protrusion doesn't look as big as the extrusion. There's some concerns with it, though. If you look at the top image, it doesn't look as big compared to the extrusion. But if you look at the bottom images, the way we really classify these are through the axial views. And for the protrusion, we're going to see the medial to lateral distance of the herniation being larger than the AP distance of the herniation. With respect to the extrusion, the medial to lateral distance is usually smaller than the AP distance of the herniation. And so the extrusions, there's a little more of a concern there because the amount of area that the herniation has taken place is a little bit less. And so there's usually a little bit more pressure on the disc with the extruded herniation. And so again, we don't see these as much in normals. We certainly see protrusions more frequently, again, but the extrusions can certainly be a concern. They're larger, and the concern now is if there's compression on nerve root related on nerve roots and causing nerve pathology and radiculopathy. Let's take a moment and look at some normal magnetic resonance imaging scans of the lumbar spine. And all of the images that we see here are what we call T2 weighted sagittal view. The T2 is a particular type of sequence with respect to the MRI. And on this image here, structures that are fluid based are going to show up whiter or brighter. We're going to call them increased sequence compared to other structures. And we're looking at sagittal views, meaning we've cut the body in half from side to side, and we're looking at these essentially left to right. And the image on the left there has some text on it, and I would take some time to look at that. That's a completely normal image except for the L1-2 area where we see a small disc bulge, and that's something that we would likely see, that small disc bulge there at L1-2 where I've placed the blue arrow. That's likely what we're going to see in asymptomatics. Also, I want you to appreciate the lumbar vertebral bodies. You can see those, and you can also see the lumbar discs as well. And I think it should be noted that the nucleus pulposus of the disc is going to have that white or bright appearance. It's going to have increased signal, and we're going to also see a darkened area around the area of that nucleus, and that's going to be the annulus, which doesn't have fluid, so that's going to show up to be a little bit darker. I think it's also important to note that where I place the red arrow, that's the plexus that you see, the venous plexus that you see in the vertebral body. That's the area of blood flow to the vertebral body. It's posterior, so you can have some fun with your friends in an MRI scan, because we've all been taught that the vertebral body has that normal square shape, but on these MR images you see a little triangle in the posterior aspect of these vertebral bodies, and that's the blood flow to the vertebral body, and blood is fluid, so it's going to show up as bright white. We also see a normal central canal in all three of these scans. Again, it's going to be bright white again because of the cerebrospinal fluid that you have there. And so, again, I think it's important to understand what normal images look like, understand the position of the disc with respect to the vertebral bodies, and we don't see herniations on these scans into the canal except for on the far left, a small herniation at L1-2. On the last slide, we showed you normal scans except for that small disc bulge at L1-2. On the image on the far left. On this scan, these are protrusions. And so these are, this is a protrusion on the left at L5S1 where I've placed the red arrow. And on the right, we see a protrusion at L3-4. And if you look at the one on the right, you can see it a little bit better, but you can see that little bit of an indentation into the thecal sac as well. So you start to see that little bit of compression there. Again, these are protrusions. About 1 in 4 asymptomatics will have these, and these are likely going to be a source of pain generation for most of the patients you're going to see in the clinic, especially if you palpate at those levels, do your PAVMs at that level, and you can recreate the patient's symptoms there. It's likely a symptom generator. So these are images that show extruded disc herniations on the left. You can see that at T1011, and then on the right at L4-5. And the concern with the extrusions at this particular point is that on both of these images you can see compression of the neural elements. And so these are likely patients who are going to have neurologic symptoms associated with these herniations. Again, we don't see these in normals. And so when you hear or see about when you hear or read an MRI report or listen to a report on the phone that says there's an extruded fragment at a particular level, those are disc herniations that I think we really need to take seriously as symptom generators, primarily because they're likely going to compress neural elements. And so when there's any time there's compression of a neural element, now we start talking about loss of strength and reflexes and sensation and positive straight leg raise and things like that. And so these are disc herniations I think that we really need to look at quite cautiously. The images on that last scan probably led you to think, well, how would you even begin to treat something like that? Those are awfully large, they're compressing neural elements. Is surgery an option for those folks? And let's talk about this for a second. And so in this particular study, this study looked at surgical versus conservative care for large disc herniations. So I'll show you the data here in a second, but they took individuals with large disc herniations and neurologic findings, and essentially they randomized them to a group of conservative care, which could be management by a physician, management by a PT, management by a chiro, medications, etc., versus a discectomy type procedure to treat that herniated level. And on the next slide, we'll show you some of the data of the participants in the study. So this slide shows you the data for the individuals who were assigned to the surgical group versus the non-operative group. Again, the folks in the surgical group underwent discectomies, while the folks in the non-operative or conservative care group pretty much had a wide variety of different activities. They didn't necessarily prescribe treatment in those particular groups. More so those patients were followed by their primary care physicians, and again they could see a variety of different specialists. They could see physical therapists, chiropractors, etc., and there was really no given treatment necessarily for that group. They just received conservative care. They didn't undergo surgery. And so you can look at the numbers here and you can see the number of individuals who had diminished reflexes, they had altered sensation, or they had motor weakness. The herniation levels you can see there, and we've talked about this a fair amount, but the majority of herniations you're going to see are going to be at L5S1, followed by L4-5. Rarely do they occur up higher than that, but they can. And if we look at the different types of herniations in the study, the vast majority of these folks had those large extruded disc herniations that we saw 2 slides back. And so these are individuals who had large disc herniations and neurologic findings. These are complicated patients. And we're going to talk about the outcomes here in a second. But before we even move forward, I want you just to think about what you think the outcomes are going to be. First off, how would you even evaluate the outcomes? And secondly, is one group going to do better sooner? Is one group going to do better longer term down the road? Or will there be no differences between the groups? Speculate and then move forward when you think you're ready to do that. I'm sure all of you have developed your hypotheses at this point, and here's the slide that kind of gives you the information that you need to know. And so we're showing outcomes from 3 different measures here. On the far right is the Oswestry Disability Index that all of you are familiar with at this point. And the 2 measures on the left of the Oswestry are measures from what's called the SF-36, or the Standard Form 36. There's 8 levels to the SF-36. 4 of them deal with psychosocial health, and 4 deal with physical health. And in this particular slide here, we see bodily pain and physical function, which are two of the domains in that physical side. And if you look at the data for the SF-36 scores for bodily pain and physical function, in that particular instrument, we know that higher scores indicate higher levels of function for the SF-36. And you can see over time, between 0 and 24 months, that the lines for the surgical and the conservative care groups are pretty much the same, meaning they both get better over time, and there really is no difference between the groups. If we look at the Oswestry scores on the right, which you're a little more familiar with, these folks came in the high 40s. And it took them some time, right, to see an appreciable drop in their symptoms. And so we mentioned a couple different times that if you're looking at how to determine if folks are successful with an Oswestry, we can do it in a couple different ways. Number one, we can look for a 50% decrease in the score. So in this case, they're starting around maybe 48. We'd like to see them drop to 24. And at what point do they do that? Because that's a successful outcome. And then if they drop down below 20, I mentioned this to you before, that it's nice to get these folks down below 20. We classify that as being minimal levels of disability. And at down below 20, that's when individuals can get back to doing higher levels of activity. And their low back pain is not the number one thing in their lives anymore, right? So they feel it, but now they can do other things and they can function at a pretty high level. And so if we look at the scores, first off, it looks like the surgical group may have had a little quicker drop by a few points than the non-operative care group, but the difference was clinically and statistically insignificant, just a few point difference between the two groups, and that really doesn't matter a whole lot. And statistically, it didn't matter either. But if you look at when these individuals had a score drop by more than 50%, it's probably approaching that at about the 3-month mark, and certainly there at about the 6-month mark. And when we start looking at scores down below 20 for the non-operative group, it takes about 6 months, and for the operative group, it takes about 3 months to get down to that point. And so that's a little bit of an interesting finding there, and they actually concluded in the study that if you want to get better sooner, go ahead and do surgery. But while the data look at these scores here, they may have dropped down below that 20-point margin at a little bit sooner. It really is the difference is not very big between the two groups is my main point here. We're talking about a few points. I think the true take-home message here is that for your patients with these large herniations is that surgery is an option, but so is conservative care. And you're going to get better at about the same rate whether or not you do surgery or conservative care. Now, I will say this, that these are individuals who had a stable neurologic examination. If at any point people start to have changes in bowel and bladder function, or we start to see progressive motor weakness, meaning that maybe the individual on day 1 can do maybe 15 heel raises on their non-involved side, they can do 5 on the involved side. Okay, so there's some weakness there. Maybe they also have a diminished Achilles tendon reflex. But now they come back on visit 2 a few days later. Now they can only do 1 heel raise. Then on visit 3, they can't do any heel raises, and there's no reflex at this point. Those are folks that are surgical candidates. That's progressive motor weakness, and that's the key criteria for somebody to potentially have surgical decompression of that nerve root. That's the first point, that you're always going to do good, sound neurologic examinations on these folks every visit, and you're going to determine if their neurologic condition is progressive or not. If it's not progressive, continue to treat them conservatively. We have good data here that supports that, but if they are progressive, they may have to cross over into that surgical group. That's the first point. Second point is there really isn't big differences between the two groups. The third point is that in order to really get patients to the point where they're truly feeling better, it's going to take somewhere between 3 and 6 months. These are individuals with chronic low back pain, chronic neurologic symptoms. It's going to take these folks at least 3 or 6 months. And I would like you to think about the time frames that you manage your patients in physical therapy. Many times we see maybe 3 visits over the course of a week, and maybe we treat them for 4 or 5 weeks. Maybe 2 visits over the course of a week, maybe for 6 weeks. My take on these patients is that you have to let these folks know up front, whether they have surgery or not, it's going to take them a while to truly feel better, right? And that you're in it with them for the long haul. And I normally tell people it's about 6 months before they're going to start to truly feel better. And if they get better before that, great. But at the end of the day, I've at least set this expectation for them to know that this is going to take time. The structural changes on your MRI are rather significant in these cases. We have positive neurologic findings, but we're going to work together to manage that. And if we all hang in there, there will be a positive outcome, but it's going to take time. And over the course of that 3 or 6 months, there's going to be an awful lot of frustration. There might be some depression on the part of the patients. We manage all of that, but we hang in there through the ups and downs, and we're looking at that end game where the patient is definitely going to start to feel better and hopefully function at a higher level. And so a lot of take-home messages from this particular study. And I'd encourage you to reflect on that as we continue to move forward in the course. And you're probably wondering how we potentially see patients in the conservative group do as well as individuals who have that herniated disc surgically removed. And part of it is there is this concept of a spontaneous resolution of a lumbar herniated disc. And this is a paper that was published in New England Journal of Medicine that shows the case of a 29-year-old woman, volleyball player who had low back pain and radicular symptoms. And you can see her initial MRI on the left showing an extruded fragment at L5 or L4-5, and then 5 months later on the right you can see essentially complete resolution of that of the extruded disc. And so, you know, the thought here is that with physical therapy, and in her case, a corticosteroid injection, which can be helpful, especially to alleviate some of the radicular symptoms that are associated with the herniation compressing a nerve root, we can see, again, positive outcomes with respect to the patient. They do mention in there about the risk of subsequent catastrophic worsening without surgery. That means that these individuals are going to potentially develop potential cauda equina where they're going to have bowel and bladder dysfunction, or they may potentially continue to have progressive weakness of their lower extremity to the point where they're really going to notice that during function. But the chances of that are really quite minimal. When we look at the individuals who have these herniated discs and we look to determine how many of them actually cross over to that surgical group, the numbers are pretty small. Doesn't mean you shouldn't still be cautious and do good sound neurologic examinations. The point here is that these discs can resolve, and I think that's part of the education you provide to your patients who have these large herniations, whether they have surgery or not, right? Their outcomes are going to be about the same. It's going to take time though, and that's setting that expectation for the patient right up front that they're likely not going to feel better in a week or 10 days. It's going to take probably 3 or 6 months before they can start to feel good and function at a high level, and that disc herniation is likely going to resolve on its own. And other authors have looked at this same phenomena. In this particular case here, this is a MRI image on the left of a extruded disc with a sequestered fragment. That's pointing to the white arrow, meaning that a disc fragment is broken off and now it's in the canal. And then we see the image 6 months later where that herniation has essentially resolved and the sequestered fragment is now gone. And there's different reasons for why this probably occurs, but the one thought that these authors give is that it essentially turns into almost an autoimmune response to the herniation, that once that disc ruptures into the epidural space and now you see compression of the thecal sac, it kicks off this response by the body where we see macrophages and other type of these cells that come in and really kind of clean up that disc material. And they mention this. I think it's truly impressive that we can see disc herniations on the last slide and then this slide here resolve in a series of months kind of on their own. So again, that's good information to give your patients, especially ones who are concerned about the herniation that they have. And this slide provides the results of a recent systematic review that looked at this concept of spontaneous regression of herniated lumbar discs. And they determined that the vast majority of these seem to regress on their own. And it seems that the highest rate of regression seems to occur for the sequestered fragments as well as disc extrusions, which is really good because those are the herniations that we're most concerned about. And so again, good information to have on your side, especially when you're dealing with patients who have these larger disc herniations. Although we do see spontaneous regression of herniated lumbar discs, there is some sequelae associated with them that we should be familiar with. In this particular image here on the top, you can see a herniated lumbar disc at L5S1. That was an extruded herniation. And you can also note that the discs above it have a nice signal in terms of the nucleus. We don't see that bright signal, increased signal with the nucleus at L5S1, so that would also be consistent with the degenerated disc on MRI, but there is a lumbar herniation in this case, extruded disc at L5S1, and it's a patient again that we've seen recently, and the images on the bottom, these are the axial images, and when we look at these, we're looking up the patient, right? So we're slicing the patient in half and we're looking up. And so if you're looking at the image on the left, right, the patient's head would be toward the back end of your computer and their feet would be out toward you if we were looking at this. So that arrow is actually pointed on the right erector spinae musculature, and that's posterior too at that particular point. And what I want you to appreciate where I have the arrows is the difference in signal intensity on these two particular images. And so on this particular image, the fat would show up bright white on these images or have increased signal. And I want you to compare the image on the left, which is a cross-sectional view at L5S1, compared to one level up at L4-5, where we see musculature that looks healthy and intact. At the level of the herniation, which again is on the left, we see significant amount of fatty infiltration into the musculature. And so when we begin to think about outcome with these individuals, we have region-specific muscular atrophy as well as fatty infiltration into the muscle. And this has been shown to influence outcome in these individuals long term. And so when we talked about our lumbar classification scheme, if you think about these individuals with disc herniation, we're going to try and get them into that specific exercise group. We're going to try and find a directional preference. If they have distal symptoms, can we centralize them? Once we get them into that group, we're going to progress them along. But, and I mentioned this before, that we're going to want to get these folks onto a strengthening program at some point. And one of the reasons is that we know that there's preferential atrophy and fatty infiltration at the level of the herniation. And if the herniation is unilateral, more so than central, we'll see more so on one particular side. And so I don't recommend doing MRI images just to look at fatty infiltration. Know that it's going to be there, and we'll talk about it a bit more in a second, but know that it's going to be there. And you can use musculoskeletal ultrasound to assess for fatty infiltration, and some of you will have that in your clinic, and I would recommend doing that with your patients. You can use it for biofeedback as well. And so in this particular case, though, our concern is that there is fatty infiltration at that one level. We can look up a level, we don't see that, right? And so that's going to be a good reason that once we get the patient moving in the right direction with our specific exercise program, we're going to want to make sure we get them onto a stabilization program to begin to treat that. The next question is, can we reverse that? Yes, we can, right? We know that we can reverse some of the atrophy that we see, some of the fatty infiltration, we can do that. We see it in other areas all the time with respect to the quadriceps following ACL reconstruction, rotator cuff following surgery as well. But in this particular case, we can definitely reverse this as well. So this is a cadaveric cross-section on top at L4. L4 is the level that we're at on the bottom right-hand corner. Okay, and you can see what that erector spinae musculature should look like. It should be full, healthy. We shouldn't see any fatty infiltration in there. Again, bottom left-hand corner, we see fatty infiltration into the erector spinae musculature. Again, that's going to be a concern because those muscles will not be functioning at the level they should be, especially at that level which is most implicated. And so the data on this have been around a while. And so this is a study that was published, one of the first studies that was done that looked at the amount of fatty infiltration and how it influences patients' ability. And we know there's a direct correlation between the amount of fatty infiltration that we see and a patient's level of ability. So if we look at these studies or these images here, you can see on the far left, no atrophy in an individual with low back pain, very low level of disability. As we begin to see atrophy creep up in the middle image, and then certainly on the right we see severe fatty infiltration, right? We're going to know that those individuals who have the more severe fatty infiltration and atrophy of the erector spinae musculature have higher levels of disability. And we mentioned before that disc herniations, we see these in asymptomatics, and we're not exactly sure of the clinical significance of a herniation. We know that protrusions and extrusions, we see these a little bit less frequently in asymptomatics, and they're likely going to be more clinically significant as we see them. But we do know that the atrophy that's caused by these herniations is clinically significant, meaning it does alter levels of ability. And that's perfect for physical therapists because, once again, we can treat the concern with the disc with our specific exercise, and we can also address the atrophy and the fatty infiltration through our stabilization exercise. So now that we've talked about some of the MRI findings associated with lumbar herniated discs, some of the management with respect to surgery and conservative care, as well as some of the other impairments in terms of motor performance with respect to the erector spinae musculature, let's talk about how these patients are likely going to present to the clinic. Because these are folks who are going to come to you with garden variety low back pain, and you're not necessarily going to know if they have a herniated disc or not unless they have diagnostic imaging. And likely, patient will not have that if they come to you, especially in a direct access mode with an acute onset of symptoms. But how do they present? Typically, it's an insidious onset of symptoms. It's something that happens slow over time, maybe over the course of a week to 10 days. They can have unilateral low back pain, or it can be symmetrical, right? The right and the left side feel about the same. The keys here is that it's usually worse with flexion-based activities. So activities like sitting and bending and lifting tend to make this worse. The symptoms are sometimes variable, meaning that you can have periods where there's little to no pain, and then for some reason the symptoms kind of kick up. And I think it's important to go back to your history and try and identify what that is, or when that happens. And I think what you'll find again is that the symptoms are relatively variable because at different points of the day there are less flexion forces going through the spine. And at the points in the day where you see more flexion activity, that's where the symptoms are likely going to increase. I mentioned before in our first lecture that mornings are typically the worst for individuals with lumbar disc herniations. Part of it is that with lying down and being recumbent, the disc imbibes fluid. And so if we look at the size of a disc in the morning compared to 8 or 10 hours earlier, the disc appears to be larger. And if you look at this imbibing of fluid, everything's a little bit bigger and there's a little bit more pressure on some of those pain-sensitive structures in the region. Evenings are worse as well. This is the way it normally goes. They wake up, they're not feeling too great, they move around a little bit, maybe do some exercise, they feel a little bit better. But then over the course of 8 to 10 hours, as these individuals are engaged in more flexion activities at work and at home, right, their symptoms tend to get worse. They're worse in the evenings as well because when we come home from work, we typically sit on the couch, eat dinner, relax, and those flexion type postures usually make things worse as well. So this is typically related to an insidious onset, and flexion type postures tend to make these worse. If that lumbar herniation is compressing a nerve, we'll get lumbar radiculopathy, and you can see the symptom chart there with symptoms in the low back region, and they're shooting down that right leg. And typically the story we hear is that the patient had back pain, perhaps as described in the last slide, and then their leg pain begins to come on. And it usually isn't necessarily an incident. It's usually something that they wake up with or they feel through the course of a day for some reason, and their leg just begins to feel different. And it's those paresthesias that are setting in. Symptoms, again, are going to vary depending upon the position, but flexion is typically going to be worse if this is related to a disc herniation. More extension type activities, they're going to feel better. If there's a motor component issue, they may have difficulty with gait. They may also report some muscle weakness. They may note that they have difficulty maybe getting up out of a chair, putting weight through that lower extremity, and certainly with walking could be worse. And for these individuals who have lower extremity symptoms, a neuro exam is going to be absolutely mandatory. We're going to want to make sure we assess reflexes, sensation, as well as strength. We also want to make sure we do a straight leg raise and a slump. And I would go one step further. In addition to your segmental neurologic examination and your adverse neural tension testing, do a central neurologic examination as well. So make sure you do a Hoffman's, you do a Binsky, and do a Clonus to see if there's any central concerns associated with this individual and their spine. And so what's the treatment for herniated disc or lumbar radiculopathy? Well, if we think back to our treatment-based classification scheme, these are folks that we're going to want to fit, likely want to fit into that specific exercise group, and they're likely going to respond to extension type activities. And on the right there, we show you a prone progression, right? Prone line, prone on elbows, prone press up, and then a standing backward bend. And we're also going to want to use our central vertebral pressures to facilitate lumbar extension. And so we see that down at the bottom. Those movements, especially the lumbar spine, are going to facilitate extension. Let's say the patient has a herniation at L5S1. Let's say you want to mobilize that segment. Maybe it's a little bit stiff. You know that's the level of the herniation. They may not be able to tolerate that, certainly at a grade 3 or grade 4 level. So you can do grade 1s and 2s there for pain relief. But if you go up to the L4 or L3 level, you're still going to feed extension forces into L5. And so I'd say if you can get up to L3 and L4, do grade 3 and grade 4 mobilizations centrally, you're feeding extension forces into L5, and you can always go back down and recheck that. And in between your bouts of central, posterior, anterior pressures, we've talked about these, doing them for about three different times for about 3 minutes each time. You can certainly try and work into some extension activities with respect to the patient there. We're also going to want to promote extension or extension-based stabilization exercises. And in the graphic at the top, on the bottom, you see bridging, opposite arm and leg, and hands and knees, alternate arm and leg on hands and knees. And so those are all going to impart extension forces into the spine. Those are all going to be extremely important to do after we activate transverse abdominis. Again, we want to promote extension with those exercises, but we also want to engage the lumbar multifidi, the erector spinae musculature, primarily because we know there's atrophy in those muscles. We know there's fatty infiltration, and we know that motor performance of extension is going to be affected. And so you may not be able to truly assess lumbar extension muscle performance, but we can certainly prescribe exercises. We also want to encourage general fitness. So walking programs will be extremely important for these individuals. I say walking because they usually migrate toward tolerating extension activities. And so I give these folks a pedometer, see how many steps they're taking between day 1 and whenever I see them on day 2, and I try and work them up. The goal is going to be about 10,000 steps we want to get these folks back to. Many of these folks have been deconditioned for a period of time because they haven't been doing activities, so a general fitness program is going to be extremely important. Walking usually works quite well for these folks. Traction is a question mark there. So we talked about traction with our treatment-based classification scheme. Traction is going to be an option if these individuals have radicular symptoms that are brought on by a contralateral or cross straight leg raise, and the symptoms are likely worsened with extension type activities. So if we see peripheralization with extension movements and we see a positive cross straight leg raise, those are the patients that are likely going to move toward traction. That traction should likely be in prone, again, in combination with an extension-oriented treatment approach. I left education, that's the first thing we're going to do. I left it out in this particular slide because we're going to cover it on the next slide in some detail. But education is going to be extremely important for these folks, and so we want to make sure we cover that. But the keys to this rehab program, trying to work these folks into a specific exercise program, usually it targets extension, using our manual therapy, again, to facilitate extension forces through the spine. When they're ready, let's go ahead and start an extension-based stabilization program that really focuses on activating transverse abdominis and the erector spinae musculature, and a general fitness program that the patient's going to work on their own. There's some key components that we know that we should include in our patient education. The first is we should never recommend or promote bed rest for these folks. That promotes more disability, more weakness, more deconditioning. We also want to be cautious about giving detailed pathoanatomical explanations for a specific cause of low back pain. I think you want to be cautious with that. We can certainly give some information to patients, but sometimes too much information about things like disc herniations and central canal stenoses, that's just too much for the patient, and they become very, very concerned about that. And so I'll usually describe it to the point that I need to get patients to understand what we're trying to do, but I don't get into detailed analysis of it to the point that it's going to make them concerned and more scared. What we should emphasize instead is the anatomical and structural strength of the spine. The spine is an inherently strong and stable structure. That's what we need to make sure we let patients know about. And that goes along with pain perception, because many times patients experience pain and they think that something is damaged. And that's just not the case with respect to the spine, right? And so I use the analogy sometimes that the fire alarm goes off in your house, and you're not exactly sure why. Number one, it could be that you just had the toaster on for too long and you burned your toast. That sets off the fire alarm. Or there's a fire in some part of your house, and that's what set the alarm off. Those are two very different situations, but the alarm is still going off in both cases. In this case here, their fire alarm is their pain perception. They see that as damage occurring to the spine. But in most cases, that is just not true. And so we can talk to them again about the spine, about the structural integrity of it, and even if they have a herniation at one level, I let them know that. Their hips are healthy. They have several other levels in the lumbar spine that are truly healthy. And that one level that we're concerned about, that's why they're here in therapy, and we're going to work on that. And we know that based upon the data, that those herniations can resolve over time, and their spine can go back to being normal. Let them know there's a favorable approach for low back pain, even for those individuals with chronic low back pain and radiculopathy, like the surgery study we spoke about earlier. Those individuals get better, right? Those individuals get better. It takes some time, and I think it's important to set that perception up front that this is going to take probably 3 to 6 months for you to start to feel really better. But at the end of the day, we're going to have some ups and downs, but at the end of the day, you are going to feel better. We want to promote a stay active approach with individuals. We want to promote active coping strategies. We also want to make sure that we get folks back into activity as soon as possible. And again, our goal is to really improve function and not just worry about pain. And so when folks are in therapy, they're working on their directional preference exercises, they're working on their exercises, they're working on improving function. And that's our main goal. We want to get folks back to activity, use positive coping strategies, right? We want to stay away from the negative side of this. Positive coping strategies, positive reinforcement, right? All of those are going to be very, very positive in trying to get the patient back to increased levels of activity. Another patient category that we should discuss is chronic lumbar radiculopathy or adherent nerve root. So these are individuals who've had low back pain with radiculopathy in the past. The low back pain has improved greatly, but the leg symptoms have never completely gone away. And so if you look at our body diagram here, we have individuals who have no low back pain at all, except they have this episodic lower extremity symptom complaint that may be related to burning or aching or even potentially numbness and tingling, similar to paresthesias. And if we ask them about their aggravating easing factors, we're going to begin to think, okay, you have leg pain, you're in the right spot. With me as a PT, I'm going to figure out what your aggravating easing factors are, and we're going to use that to prescribe some exercises for you. But they're going to, and you may ask them about sitting, and they're going to tell you that it really doesn't bother me with sitting. Sitting feels completely fine. What about walking? Well, walking really doesn't bother me either. In fact, walking actually makes it feel better. Walking makes it feel better because they stretch it out. They stretch the nerve root out so they actually feel better with a little bit of mobility. Where you'll see limitations with them will be on their physical exam, specifically flexion range of motion. Flexion range of motion will be a problem because their motion will be limited because of the stretch and the tension that they're placing on those neural structures. They'll also note a sharp pain typically as they move forward into that forward flexed posture. And you'll also note that in this particular body diagram here, this individual has left-sided lower leg pain. They'll deviate toward that side to take tension off the nerve root. So when they flex forward, they'll deviate toward the left, right? They'll deviate toward the left, and you may say, that may look like an aberrant movement, right? But it really isn't. It's just related to the fact that when they move forward, bend forward, they've learned to shift toward the left a little bit to take tension off that nerve, the nerve structure. When we look at these individuals, because they have leg pain, neuroexamination will be mandatory, and we're going to want to make sure that we address lower limb neural tension in the form of the straight leg raise as well as the slump test, because this is really going to show us that this individual has an adherent nerve root, and it's something that we're going to be able to manage. We've talked about the treatment-based classification scheme so far in some detail, and you look at it and you say, well, where would these patients possibly fit? Right? They're not going to fit in a specific exercise category, likely because they don't necessarily have a preference toward flexion or extension. They're likely not going to fit in the traction category because they won't have a positive cross straight leg raise, and they won't necessarily peripheralize with extension. You'd say, well, do they fit the stabilization or manipulation, manual therapy? They could work into those groups, but it really isn't for the reason that we would want to treat these folks for that adherent nerve root. In fact, if we look at the classification scheme, I think if they had to do it over, I think they would have a classification there for individuals who had adverse neural tension. Right? And so that'd be like a fifth category. When we look at folks who have a positive straight leg raise or a positive slump test, and they're chronic, meaning they're not severe, they're not irritable, their disability levels may not even necessarily be that high, right? But we have to treat them through a very, very specific series of exercises that deal with addressing the mobility in the nerve root. It doesn't really fit in these categories necessarily. It should be like a fifth category, because these patients, when you address that specific nerve root limitation, you'll see they get better much quicker, and the improvement is much larger in these individuals who have that specific treatment added to their training program. So to treat these individuals who have chronic lumbar radiculopathy and adherent nerve roots, we're going to start with education. And the education is going to employ many of the same principles we spoke about previously. First and foremost, we're going to make sure these folks continue to stay active within reason. They avoid things like bed rest. And we'll describe to them that this is likely related to that episode of low back pain and leg pain they've had in the past, and that nerve root just hasn't completely recovered. And if we can regain some of the movement, right, in that extremity, based upon where that nerve is going to be positioned, we can get them better. And so we're going to carefully address that neural tension. These are folks who are going to have a positive slump. They're also going to have likely a positive straight leg raise. And if you begin to add some of those variants that we spoke about, they're likely going to have an increase in symptoms. And so if we sensitize these tests on top there, we sensitize the test with a little bit of ankle dorsiflexion, adduction to bias the tibial nerve, we may get symptoms with that, right? So this is going to be a positive test. And so in this particular case, we want to address those. Now, these are not patients that are irritable. These are not patients that are severe, right? These are patients who are chronic. Their condition is relatively stable, and we feel comfortable addressing nerve tension issues. And so if you look at those two images in the bottom of the screen, in the bottom right-hand corner, what it shows is slump stretching that we see typically added into a treatment program, as I'll describe in a minute. But these are slump stretching procedures that are added in to a manual therapy program that's addressing local impairments in the lumbar spine. They're added into a stabilization program that's addressing some of the muscle deficits that we see in folks who have chronic low back pain. And the bottom right-hand corner, that's the therapist-assisted technique. So we put them into a long sitting position with their feet up against the wall in ankle dorsiflexion. We have the patient slump, and then the therapist flexes the cervical spine and applies some overpressure to the point where the patient's symptoms begin to come on. And they hold that there for 30 seconds, and then they back it off. Let the patient rest. Do it again for 30 seconds, and they repeat that 4 or 5 times per session, in addition to a treatment program that addresses some of the manual therapy deficits that we see, as well as a stabilization program. And then in the bottom right-hand corner, again on the left, that's the home slump stretching exercise that they go home with. And so again, they sit in a long sit type position. Their feet are up against the wall, so their ankles are in dorsiflexion. They slump. She's using her hands now to overpress her cervical spine to bring on those symptoms. And then she tries to hold it there for 30 seconds and then backs it off. And then repeats that 4 more times. So it's 5 repetitions for about 30-second hold. Again, this is in conjunction with a manual therapy program that's addressing local impairments, as well as a stabilization program. And of course, we're going to employ general fitness activities as well to try and get these folks back, especially if they're limited with respect to their work activities at this particular point. Walking works really well for these folks. Stationary cycling works really well for these folks as well. So any type of fitness activity we can get them into will likely help the mobility of that nerve root. And so I think it'll help if you see the results of a study that specifically managed folks who had this. These are individuals who potentially had positive slump tests, and we sorted them out. So half received a manual therapy and stabilization exercise program. The other half received a manual therapy stabilization exercise program in conjunction with slump stretching, as we just previously described. Let's look at the outcomes. So again, these are folks who have positive slump tests, right? We manage these folks with manual therapy and stabilization exercises I previously described, but we're also giving them slump stretching like we spoke about previously. And I want you to pay particular attention to the outcomes here. So we have 3 different sets of outcomes. The first is from the Oswestry Disability Index. The second is from the Numeric Pain Rating Scale. And the third, they actually looked at a fear avoidance questionnaire to see how patients did with that. And so if we look up at the top, we see the Oswestry Disability Index scores at baseline, 1 week, 2 weeks, 3 weeks, and 6 weeks. And if we look at the light circles, that's the group that just got manual therapy and stabilization exercises. If we look at the dark squares, those are the individuals who received manual therapy and stabilization exercises, and they also had the addition of slump stretching as a home program and an in-clinic intervention. And remember, that slump stretching, as I described it, is only about 3 or 4 minutes, right, in the clinic, and then 3 or 4 minutes additionally once per day at home. And so we're not talking about a lot of additional time added into a program. However, when we look at the outcomes are pretty interesting here. So both groups started pretty high at about a 60 with respect to their Oswestry, which means they came in with a pretty high level of disability. But if we look at what happens over time, at 6 weeks, right, we see that group who received the slump stretching almost approaching that 20 mark that we talked about as kind of that magic number where folks really start to feel really good. And we also see a significant drop, much more than 50% in that case. So that group had a very positive outcome. Contrast to that, to the group who had just the manual therapy and the stabilization exercises, they started around 60, and then 6 weeks later, they're still up at a 40, which is still a moderate level. Moderate, almost a high level of disability at that point. So those folks, yeah, they had a bit of a change, but still, at 6 weeks, they still had 40 on their Oswestry on average, which means they still had a high level of disability. If we look at the pain scores, we see the same kind of a trend. And then if we look down at the FABQ scores, we see the same thing. These folks started with some FABQ scores that were a little bit higher than we would like. And so these are individuals who probably had some fear avoidance associated with their condition. And if we look here, though, over time, we see that, again, the individuals who received the slump stretching did much better with respect to fear, right? than the individuals who did not receive that. And again, it deserves mention that the treatments from a manual therapy perspective, they were central PA pressures, right, at the stiff segments. And then the stabilization program is the same one we've described to you before. And so the addition of just that few minutes of slump stretching really had dramatic outcomes for these patients. And so the take-home message is that if you're dealing with patients who do have positive neural tension, that at some point in the treatment plan, you have to address it. Now, if they're more acute or even subacute, you have to be cautious because that nerve tissue is going to be very sensitive. And if you start cranking on it too hard, you can make these patients worse. Again, these are patients who are more chronic, right? They have a history of low back pain in the past and radiculopathy, and now they're kind of left with those symptoms related to an adherent nerve root. And so in this particular case, again, the outcomes pretty amazing that just with that additional 3 to 4 minutes of the slump stretch, they had significantly better outcomes. But that's really what the focus of that treatment would be for this particular patient group. Let's talk a little about lumbar stenosis, and I failed to mention this when I spoke about disc herniations, but that's a population that is usually younger, meaning that the mean age of that study that we spoke about by Weinstein that looked at surgical versus conservative care for disc herniations, mean age was about 42 years. And so you'll see patients in their 30s and 40s typically who are dealing with lumbar disc herniations. They may be a little bit younger than that or perhaps a little bit older, but the mean age will typically be early 40s. This is a very different clinical picture when we start talking about lumbar stenosis. These are typically folks usually in their 60s, maybe their 70s, who are coming in complaining about this long-term, maybe chronic low back pain that they describe as maybe some stiffness or an occasional ache. Their main concern, though, is cramping in one or both legs, and this typically occurs with walking or extension-based activity, and it's always going to be relieved with sitting. The reason is that sitting opens that canal. Extension type activities like walking, especially trying to walk really tall, narrows that canal down, and it's going to provide compression on those neural structures that go ahead and innervate the lower extremities. And so the key here is to know that these are folks who are older. Extension-based activities are going to bother them. Flexion makes them feel better. If you're already thinking about our treatment-based classification scheme, these are folks who are going to fit in a specific exercise category. But flexion-based activities, much different than the extension-based activities, we're going to give folks who have disc herniations. These are individuals who respond to flexion again. And because they're going to have chronic low back pain, they're likely going to have motor impairments. So they're going to get stabilized at some point. But our primary goal is to try and get them into a flexion-based activity. Neurologic examination is going to be mandatory because of the symptoms in the lower extremity. So at a minimum here, we want to make sure that we see reflexes, myotomes, and dermatomes assessed in these folks. I would also go ahead and assess slump as well as straight leg raise because there could be some findings there. There could be some adverse neural tension associated with these folks as well that we may need to address. Take a moment and review this brief video that describes a clinical prediction rule that was developed by Cook et al. In 2010 to help you diagnose individuals who have lumbar spinal stenosis. This graphic here shows some of the concerns that we see from a pathoanatomic perspective with central canal stenosis. If we look at the image on the left, we see an open, patent spinal canal, no pressure on the spinal nerves. The spine is mobile and flexible, and there are no symptoms as the individual is in extension with respect to pain, numbness, or tingling down the legs. If we look at what happens over time, though, with aging from the spine, we see ligaments that get thicker. Specifically in that case, that's the ligamentum flavum that appears to hypertrophy. We see chronic disc bulges. We also see bony hypertrophy of the facet joints. All three of those combined can narrow the central canal. And again, extension activities are going to bring on that pain, numbness, and tingling. They're going to note with walking their legs may feel weak or cramping, and the pain is going to be relieved by flexion, primarily because we're opening that canal. That's been narrowed based upon some of those pathoanatomic changes at the canal. When we consider the differential diagnosis of lower extremity pain in older individuals, neurogenic claudication, as it's related to central canal stenosis, is in the differential for sure, and vascular claudication will be there as well in these older individuals. And what we mean by that is the lower extremity vasculature is now stenotic over time due to changes in those vessels. And so both of these are situations where individuals are going to present with lower extremity symptoms typically related to activity. The differences here are that with neurogenic claudication, there will be a directional preference, meaning that these individuals will not be able to walk for prolonged periods with the spine in an extended posture. However, if we flex that spine, that'll make things a little bit easier for them with respect to activity. Vascular claudication, with respect to activity, it really doesn't matter if the spine is flexed or not. They're going to have limitations in activity due to a lack of blood flow to the lower extremities. The other concerns with this is that if we look at some of our physical examination findings, individuals with neurogenic claudication will typically have a complaint of back pain, and their spinal examination with respect to range of motion will be limited. We won't see that in individuals with neurogenic claudication. As well, if we look at neurologic findings, there could potentially be some neurologic findings with these individuals. We won't see that with the vascular claudication folks, and if we go ahead and assess lower extremity pulses, there typically will not be a problem if we're only dealing with neurogenic claudication, but if vascular claudication is present, we may see diminished or absent, even asymmetrical pulses of the lower extremities. And so this chart really is good because it helps dichotomize whether or not the symptoms are related to neurogenic or vascular claudication. The truth of the matter is, though, when you're dealing with individuals in their 60s, 70s, even into their 80s, there's likely a mix of both here, right? So we're likely going to see folks who have some neurogenic claudication, but there's also some vascular claudication as well. And so we can determine if one is more present through some of our testing, but at the end of the day, neurogenic claudication and vascular claudication will likely be coexisting in many of our patients. One test that you'll commonly see used to determine if an individual has neurogenic claudication or central canal stenosis is a shopping cart sign. Again, we've mentioned that individuals who have neurogenic claudication or due to central canal stenosis are going to have difficulty walking with their spine in a more erect or extended posture. They can continue to walk if they stoop forward. And so the shopping cart sign is such that this individual, now bent forward a little bit using the shopping cart for some support, can continue to walk with less symptoms. If the symptoms are going to be due to vascular claudication, it doesn't matter if the individual walks straight or if they stoop forward, because those symptoms of the vasculature, from the vasculature, are not related to spinal posture at all. And so you won't hear about a shopping cart sign in an individual who has vascular claudication. What we'll typically see is that folks with neurogenic claudication, again, feel much better when they're leaned forward a little bit with the shopping cart for support, because that opens up that canal, and we won't see that same symptom improvement with respect to vascular claudication. Two other special tests that I want you to be aware of are the bicycle test of Van Gelderen and the treadmill test. Again, these are tests that are used to determine if an individual has neurogenic claudication. And so the bicycle test of Van Gelderen, we'll show you a video on that in a second. If an individual has central canal stenosis, we look at different postures on the bike and determine how that changes their symptoms. So for example, we will start an individual on the bike, stationary bike, with an erect posture, maintained lumbar lordosis, so the spine is in some extension. We have them pedal. Once their symptoms come on, we then have them flex forward, and if it's due to central canal stenosis, they'll note improvement in their symptoms when they flex forward. If, however, it's due to vascular claudication, it really doesn't matter if they flex forward or not. Those symptoms will be consistent and likely worsen over time on the bike, regardless of the position of the spine. The treadmill test, and like I said, we'll show you a video in a second on that bicycle test. The treadmill test is another test that we can use. And typically what we'll do here is we'll put a patient on a treadmill, and we may have a set period of time, say 5 minutes. And we'll let them walk at a set speed, for a set period of time, and we'll see how far they can go. We're going to ask them to walk at a comfortable pace. And maybe we set the treadmill time for maybe 5, 7, or 10 minutes. We see how far they can go with a flat treadmill, no incline. And then we put them on the treadmill, and we ask them to do it again at the same period of time, same intensity, but now we add an incline. And that incline is going to cause the spine to be flexed a bit. And so the two photographs on the slide here, on the left, we see an individual walking on a flat treadmill. On the right, we see an individual walking with on a treadmill with some elevation. That elevation will flex the spine a little bit. Now, it may not necessarily change symptoms per se, but it may influence performance, because with that spine flex forward a bit, the symptoms just may not be as powerful, and so they may be able to walk further. And so a positive treadmill test would be that the individual can walk further for a set period of time and a set intensity with the treadmill on an incline versus having the treadmill flat. And so if, again, we're dealing with vascular claudication, it really won't matter how or on the angle of the treadmill, because it's vascular and it really doesn't matter with respect to position. Take a moment to review the video here on the bicycle test. And the bicycle test can be used to differentiate, again, between neurogenic and vascular claudication. Neurogenic claudication, the symptoms are going to change as the individual rides in an extended posture and then switches to a flexed posture. If it's vascular, those symptoms will not change at all. When we think about treatment for lumbar spinal stenosis, we're going to use some of the same principles that we've used before for other disorders. First off, we're going to make sure that we educate the patient, and our education is going to be basically driven toward them understanding about what the pathology is that they currently have and how we really want to minimize inactivity and not utilize things like bed rest, but encourage them to be more active, especially in the activities that we're going to give them. We're going to prescribe specific exercises, so those are going to be geared toward flexion. We give you some examples on the right here, on the photograph on the top. And then we're going to use manual therapy. And manual therapy is going to be used to try and improve mobility at the lumbar spine and the hip. And when we think about manual therapy, at least what we've done so far with your class, we're going to use our central and unilateral vertebral pressures as well as transverse pressures to try and improve mobility. Typically, these individuals have a hard time lying prone for prolonged periods, so we're going to place some pillows underneath their pelvis so that they're lying on their stomach with a little bit of a flexed posture, and we're going to use central pressures. If there is a painful segment, I'd recommend kind of moving away from that for the period of time until the person feels better, or potentially use grade 1s and grade 2s, or potentially just use transverse pressures on those levels. But we're going to want to use manual therapy to try and improve general mobility of the spine. The hip's going to be important because in our experience, we've also seen that the hip flexors have been tight and hip extension's usually been limited. So the hip extensor, or the hip flexors rather, are going to limit hip extension from a musculotendinous perspective, but there could also be some tightness at the joint in the capsule that's limiting hip extension as well. So we want to use our muscle stretches as well as our joint mobilizations to improve hip extension. We want to eventually prescribe a core strengthening stabilization program. Again, all of that's going to be based upon this abdominal drawing in maneuver, getting the transverse dominus activated, and then we're going to proceed from there. We have to be cautious with implementing stabilization exercises that introduce a lot of extension early on because they may not be able to tolerate that, but we can certainly begin to try to use this supine hook-lying position here with a nice transverse abdominis contraction and just begin to work on some subtle movements of the lower extremities. We can have them maybe do a heel slide, bring the knee up toward their chest, or potentially even do some lower trunk rotations associated with that. Anything we can do just to begin to get some stabilization activities. And then with respect to general fitness, we want to improve that as well. And so stationary cycling is something that usually works quite well for these individuals because we can get them to do that early on. And then treadmill walking on an incline is another activity that we can get these folks involved with. Pool, I don't have that on the slide, but a pool type program, aquatic therapy would be helpful as well. And so finally, we're going to address this from multiple different perspectives, but we certainly want to get some specific exercise moving with these folks in the flexion, targeted manual therapy to address the lumbar spine and the hip, specifically improving extension range of motion through both. We want to make sure that we start them on a core stabilization program, implementing extension type activities as they can tolerate, and then general fitness as well. A couple of other treatments that we can use from a manual perspective to treat patients with spinal stenosis. The first on the left there, using PIVMs. We taught this as an assessment technique, but can also be used for treatment to specifically PIVMs into flexion. So a couple bouts for 2 or 3 minutes, moving these individuals into flexion is typically going to help. We can even move them into a little bit of extension as well as they start to feel better, just to improve some general mobility and decrease stiffness. We're also going to address the hip, and I mentioned this previously, but we're going to address the hip because if we can gain extension from the hip, that's going to assist the lumbar spine. That's not going to have to extend as much to get patients through typically that stance phase of gait. So it's been our experience that the hip flexors are typically tight and the hip joint is tight as well. And so we want to stretch the hip flexors. That hip flexor stretching that you see the image of the 3 and 1 in the middle. Her left hand is stabilizing the pelvis. I think it's important to stabilize that pelvis in a posterior pelvic tilt. I would also dose these stretches out 3 to 5 reps, at least 60 seconds. In this population, this is going to be most indicated. And then looking at hip joint mobilizations from a PDA perspective, that's going to improve extension as well. Again, these individuals lack extension, and extension forces through the spine increase their symptoms. So if we can improve extension at the hip, and even improve some general mobility through the spine as well, through some other levels that may be stiff, that's going to help a great deal at helping these individuals function at a much higher level. And it's been shown that these conservative plans to care are as effective, if not more effective, than surgery for these folks with respect to decompressing the lumbar spine. And so let's take a moment and discuss spondylosis of the lumbar spine. And this really relates to degeneration of the intervertebral discs. And the image on the bottom right shows a normal spine on the left and a spondylitic spine on the right. And we begin to see some narrowing at the intervertebral discs. We also potentially see some bone spurs there as well. And remember, those discs serve an important function. When we start to lose that function, we begin to see some of the neural foramen begin to narrow. We may see facet joint loading patterns change with that. And so the mechanics of the spine really begin to change. We show you the body diagram there on how patients may present with respect to pain. It's typically going to be symmetric, but you could see asymmetrical low back pain, one side more so than the other. It's going to be localized typically to the lumbar spine region. We'll see it typically most at L5S1 followed by L4-5. And it's episodic, meaning that these folks are to complain about chronic pain and stiffness. And they'll come on, maybe they'll get an episode every few months, but then over time, the period between those episodes begins to decrease. And so it used to take every couple of months, so they get an episode and they recover, and then it'd be a couple of months. They get another episode, and now it's down to the point where they have an episode and it's maybe a week or two. And so the time between those episodes has decreased substantially. And so again, this is degeneration of the spine. These are primary complaints of stiffness and pain in these individuals, usually localized to the lumbar spine. These are usually individuals in their 50s and 60s at this point. And potentially, some of this may be a precursor to developing stenotic symptoms, because these folks are on the road to that. Again, when you start to see narrowed intervertebral discs, the facet joint loading pattern begins to change. You start to see hypertrophy in the facet joints. As that disc space narrows a bit, you may get what's called thickening of ligamentum flavum, but it's more like a buckling of ligamentum flavum as the space begins to narrow. So you could see an increase almost in ligamentum flavum size, and all that kind of contributes to it. So these are the individuals who have a degenerative spine, but it hasn't gotten to the point yet where they're dealing with stenotic symptoms down the leg. The treatment for these individuals will deal with education first and foremost. We want to educate these individuals as to activities that they should be doing with respect to their spine. We also want to talk to them about the effects of inactivity and things like bed rest. We don't want them to do those activities, and so we want these folks to be active. We will talk to them about pain as well, and some of the changes that are going on in their lumbar spine and why they may be having some of these symptoms. Our first goal from a treatment-based classification system is to determine if these individuals fit in a specific exercise category and if there's a directional preference. They're likely not going to have lower extremity symptoms, so we really can't determine if there's centralization or peripheralization. Instead, we're looking to determine if there's a directional preference. Part of the goal with that is to mitigate symptoms, but also to really improve general spinal mobility. Again, we can use manual therapy. These folks are going to have complaints of stiffness as well, and so we can use manual therapy. Our central techniques, our unilateral techniques, as well as our transverse pressures to improve general mobility at the spine. Same principles apply as before. If we're dealing with individuals who potentially have a segment or two that are tender to palpation, we're going to use grade 1s and 2s on those and treat the pain, and we're going to work away toward the other areas of the spine, letting the patient know that our general goal is to increase mobility. We're also going to address the hip, so there's likely going to be some mobility issues at the hip, just like with respect to individuals who are stenotic. Hip flexors are likely going to be tight. We're going to want to make sure we stretch those. I would also address the piriformis, as we had spoke about previously with respect to the hip, address that, and maybe even the hamstring musculature as well. And so address the tight hip musculature. Also, you can use manual therapy at the hip, just like we spoke about with individuals who are stenotic. In this particular case, you can use long axis distraction, you can use lateral joint mobilizations, you can use those PA mobilizations we just talked about as well. Anything to try and improve mobility at the hip. It's likely that these individuals may have some early onset hip OA as well, and that's contributing overall to this. And so moving down to the hip will be important. And then we're going to want to make sure that we employ a general stabilization exercise program. We know these individuals have had pain for likely long periods of time. They're likely going to have some weakness of the abdominal musculature as well as the lumbar extensors, even the glutes, hip abductors, hip extensors. So we're going to address all of that, and then general fitness activities as well. So if they can't walk for prolonged periods because it irritates their spine, let's get them on a bike. If we can get them in a pool, that's even better. For some of these individuals, just get them moving. If they can walk, let's get them on a program for that. And so anything we can do to try and get their fitness activity improved is going to help. Again, these are folks who are a little bit older. I haven't mentioned this with the other areas, but they may have some general medical comorbidities. Some of these folks may be diabetics. They may have high blood pressure or other cardiovascular concerns. So exercise, if they're cleared for it, will be very, very helpful for these folks, not only with respect to their spine, but for some of their general medical issues as well. We've talked about stabilization exercises in the past, and I would go back to this particular program for these folks. If they don't have a directional preference, they can usually work through these exercises without much of a problem, meaning that even the ones that move that spine into extension, they can usually tolerate those. And so upper left-hand corner again, that's going to be that abdominal hollowing or transverse abdominis activation type activity, and then transverse abdominis will be activated through all the activities that we're going to do and progress these folks as tolerated. We've presented this slide to you before on how to progress these different activities. And I mentioned this already with respect to the individuals who have lumbar spinal stenosis, that we can begin to get them started with some abdominal bracing, abdominal hollowing maneuvers. And if they're not quite ready to move into some of these extension type activities yet, we can do bracing with heel slides, bracing with leg lifts, bracing with a little bit of marching. So we can use all that. And then for individuals who just have a spondylitic type spine without the central canal stenosis, we should progress them through these activities. And so I think it's fair that you understand the core group of exercises for lumbar stabilization, but also feel comfortable knowing how to progress each of these activities and have a plan to be able to do that. And so I look at the transverse abdominis component here, and there are at least 5 or 6 different activities there that you should feel comfortable progressing a patient through as they begin to get better, because we don't want to underdose exercise in these individuals. We want to make sure that we continue to challenge the neuromusculoskeletal system with our exercise prescriptions. We want to be safe, but we want to dose exercise effectively so we continue to get a training effect. So 2 other conditions that we need to speak about are spondylolysis and spondylolisthesis. Spondylolysis is going to deal with a defect in a region of the spine that we call the pars interarticularis. Now the pars interarticularis is going to be the junction between the inferior and superior articular processes of the facet joints. And you can see that on that image of the skeleton there, the spinal skeleton on the right. And that middle arrow, when it points to facet joints, is showing a defect in the pars interarticularis. So these are essentially fractures, potentially even fatigue or stress fractures through that area of the pars interarticularis. Spondylolysis would indicate a fracture through the pars interarticularis. It could be either unilateral or bilateral, but there's no appreciable movement of that vertebral body relative to its neighbors. With respect to a spondylolisthesis, we see a fracture of the pars interarticularis, so there's an underlying spondylolysis, but the listhesis component now means that there's migration of that vertebral body relative to its neighboring segments. So in this particular case here, we see the spondylolisthesis in this particular case is one of L5 moving forward with respect to S1. And so that's going to be the spondylolisthesis component with respect to movement. And so to evaluate if a spondylolisthesis is present, we would use plain film x-rays for that. On the left is a patient that I have seen in the past who had been diagnosed with a grade 2 spondylolisthesis. The arrow points to the pars defect. If you refer to the notes section of this particular slide, excuse me, I also have the radiology report there for you. We grade these out based upon the 4 quadrants of the sacrum. And so on the right, that's another individual who has a grade 1 spondylolisthesis. And so that dark arrow is positioned at the pars defect, and we're looking at a slippage anywhere between 0 and 25% forward on the sacrum. That'd be a grade 1. Anywhere between 25 and 50% slippage would be a grade 2, etc., for grade 3 and grade 4. And so a grade 2, we see that on the left. This is an interesting individual. He's in his early 30s, and he had played offensive line in high school, which was a lot of extension type forces, being driven back into extension, playing an offensive line position, do a lot of blocking in that position. And now he works as an auto mechanic, does a lot of overhead work with cars that are up on top of a lift, so he's positioned in extended posture for prolonged periods there, and he enjoys weightlifting. And one of his favorite exercises is doing military presses, and I had seen him after he had injured his back doing military presses in the gym. He always had low-grade chronic low back pain all the way back through high school. I'd never been seen for it until he injured his back doing military presses, and it's likely that extension force probably put him over the top at that particular point. He likely may have had a pars defect in the past. He may have also even had some anterior slippage, maybe some degree of spondylolisthesis, but for some reason that military press really put him up over the top. And we did get plain films on him, and he had a grade 2 listhesis, as you can see. There's also some degenerative joint disease, degenerative disc disease between L5 and S1. You can see the disc space there is narrowed a little bit as well. And so again, you can grade these out anywhere from a grade 1 to a grade 4. And we'll talk more about how these folks present here on the next two slides. So let's talk about patients who have an isolated spondylolysis. So this would be a defect in the pars interarticularis, but they would not have any slippage yet. And so these folks are likely going to have low back pain. It could be due to excessive repetitive force or potentially a single trauma. These are individuals who can usually sit and stand without a problem, but when they move into extension or even potentially loaded side bending, they have pain associated with that. And because this is a fracture, right, we're going to do a neuro exam, right, because we don't know if it's a spondylolysis or a spondylolisthesis without plain films, but if that's in our differential, we want to make sure that we do a good neurologic examination, because as the nervous system is involved, that really elevates the concern for this particular patient. The presentation of a spondylolisthesis is very similar to that of a spondylolysis. These are individuals who are likely going to have low back pain. It could be unilateral or it could be more symmetric and bilateral. They may complain about this stabbing and catching when they move their back. And so these are the individuals who could potentially have those instability or those aberrant movement patterns that we spoke about when we discussed treatment in a spinal stabilization category. These folks can tolerate flexion activities usually without a problem, but it's activities that involve extension. And the extension type postures are a concern because we now load those posterior elements and it pushes that segment forward. And so when we talked about the patient 2 slides ago that I had seen, his instigating incident was really these overhead military presses that, as you know, if you're doing them properly, your lumbar spine will be in an extended posture. And as you're elevating that weight overhead, that vertical load down on the spine was probably enough just to set him off. Because there sometimes is also a component of degenerative disc disease, transitioning movements, so moving from sit to stand, or sometimes even supine to sit, can be painful, especially if they've been there a while. And then they may have difficulty standing upright, almost like these individuals who have lumbar spinal stenosis. They really want to avoid that end range extension. Again, because we're dealing with a fracture, and in this case, a slippage forward, a neuro exam is going to be mandatory. And I'll say this, usually if we're dealing with individuals, especially ones who have probably more than a grade 2, but if they have a positive neurologic finding, those are individuals who potentially are surgical candidates to stabilize that lumbar spine, because that slippage forward can pull on those neural elements. It can cause symptoms that could be consistent with cauda equina if it's bad enough. And so again, a neuro exam, reflexes, strength, sensation will be important. So with respect to management of patients who have a spondylolysis or a spondylolisthesis, these are individuals who are going to fit, and when we think about our treatment-based classification scheme, into the stabilization exercise component. Although they may have a bit of a directional preference into flexion, it doesn't necessarily make them better. It's just a less provocative movement. So while we may work them into spinal flexion a bit, their main treatment is going to be spinal stabilization. And let's review a study that was done that looked at the management of these folks. And so 42 subjects were enrolled in this study. 21 subjects received a 10-week training program that dealt with spinal stabilization, focused on the deep abdominal and erector spinae musculature. And then the other 21 were dealt with respect to medical treatment by their physician. And we'll review the exercise program again for you on the next slide. We've reviewed the stabilization exercise program in the past, but this is the exercise program that was utilized in this particular study. Again, it focuses on activation of the deep abdominal musculature as well as the erector spinae musculature through a series of exercises that are progressed as tolerated. And before we move on to the next slide, I want you to take a moment and consider what you think the outcomes for this study might be, right? They use an Oswestry disability index prior to starting the study, and then they reassess them down the road. But think if there's going to be a difference between the groups and at what point that difference would likely manifest. And so our outcomes look at a visual analog scale for pain intensity and then the Oswestry disability index. index. The VAS scores are on the left, the Oswestry disability scores are on the right. For each of the graphs, the control group is noted with the dark squares, and the specific exercise group is noted with the light circles. And so we can see that both groups started about the same for the visual analog scale scores, between a 5 and a 6 for both groups, and then for the Oswestry Disability Index, probably around a 25 or so. It's important to note that the disability levels in this particular study are a little bit lower than the ones we see in other studies. These are individuals who are a little bit younger, so the average age for the subjects in this trial was about 30 years old. These are folks who are usually pretty active, and so their disability levels aren't necessarily as high as we might see with folks who have disc herniations. But if we look at the scores for the VAS, we see that we got a nice drop at that post measure. That's at 6 weeks. A nice drop almost down to about a 2, while the 20 rather, and then while the control group stayed the same at about 50 on the visual analog scale. And you can see the control group stayed about the same through the course of the study, whereas we saw a nice drop at 6 weeks, and that drop maintained out to 30 months, which is a really nice outcome. With respect to the function scores, we see a similar trend here. And so both groups started at about 25, and at 6 weeks we see that the control group stayed about the same, while the specific exercise group dropped down to about 15 and stayed there for about 30 months. Now, they did maintain their exercise program during that period of time, but there's a couple of interesting findings here. Number one, these are folks who have a known spondylolysis or known spondylolisthesis. I said this to you before. When you begin to judge an outcome, you can look at the Oswestry Disability Index and look for either a 50% drop in the Oswestry, or if the score kind of starts a little bit lower, did they get down below 20, right? That's going to be the key. And when they get down around 15, in this particular study here, that exercise group got down around 15, that's about the cut point where we allow people to begin to get back to playing sports. And so they were able to achieve that level where they're likely to get back to high levels of activity. If we look at the control group, they stayed about the same. Really no change at all in their condition. And so this really provides good evidence that get those folks in a stabilization program, and they're likely going to have a nice outcome at 6 months. And we can maintain that and then get back to high levels of activity as well, despite those anatomic defects. And so in light of the discussion with respect to treatment already for this group of individuals, let's talk about a few more components. First is going to be education, right? We're going to make sure we educate these folks as to what they should and should not be doing for this period of time. I think while they're in rehab, we want to minimize stress on the spine, so we're going to limit extension-based activities either in recreation or sport, and potentially at work as well. We're going to modify those. As I mentioned previously, these are folks who are going to like flexion-based activities. And so we can still use those, right? We can still use things like knees to chest, single and double. We can do things like a posterior pelvic tilt. Again, we can train them into a stabilization program based upon flexion. They could even do things like partial sit-ups and crunches and things like that. That's not going to bother them. So they're going to have a specific directional preference toward flexion, and we can mobilize them in that direction. We can use targeted manual therapy to address some other deficits. Again, almost like the folks who have central canal stenosis, these are folks who need extension from the system. They're going to be a little bit limited in what their lumbar spine can provide because of that defect, either at L4-5 or L5-S1. And we want to look at the hip, because if the hip is limited at all into extension, we can get that back, and that can help these individuals a great deal. And so again, we can stretch the hip flexors if they're tight, and you see that in the image down on the bottom. And we can also mobilize the hip, right, in that posterior to anterior direction we spoke about before to facilitate hip extension. And that's going to be very helpful for these individuals. We can get some hip extension from the hip. And then we can even begin to mobilize the lumbar spine. I wouldn't mobilize the fracture segment, right? That's a contraindication to even do thrust manipulation there, but you can work up into the thoracolumbar junction away from that fracture, right, and work the lower thoracic spine, upper lumbar with your central PAs, your mobilization techniques, and I think just to try and get some general mobility through there if they're stiff. Again, if we can get a little bit of extension above that segment that's injured, that's going to be very helpful. Like I said, we want to be safe with that though. And then the activities that are going to benefit these folks the most is going to be core stabilization. Core stabilization focusing on the program we spoke about previously. We're going to activate transverse abdominis and then make sure that we get the erector spinae musculature going as well. And then we can get these folks into a general fitness program as well. Stationary cycling is usually tolerated quite nicely by these individuals. And treadmill walking during the rehab component, where we elevate the treadmill a little bit, get it on an incline, and that introduces a little bit of a flexor moment into the spine, and they can tolerate that activity. And so keeping these folks fit from a cardiovascular perspective while we're rehabilitating them is going to be key, because like I said, these are individuals who are a little bit younger and may want to get back to sport. One additional treatment that I would recommend that you utilize is electrical stimulation of the lumbar erector spinae musculature. And then so when we do this, we're looking to get these contractions of the erector spinae musculature to help facilitate the other aspects of our rehab program. Like the individuals who have spinal canal stenosis, these folks don't tolerate extension forces very well, so we lay them down and prone over a couple of pillows, and we strap the pelvis into a posterior pelvic tilt as well, and then we apply the pads in parallel on each side of the spine. And so we're looking for contraction of both the right and left erector spinae musculature, and we're looking for anywhere between 12 to 15 contractions. The contractions last about 15 seconds, and they can be off anywhere from 45, and then you get a period of rest, 45 to 60 seconds. And we're looking for, again, for about 12 to 15 contractions. And we have the PT standing right next to them while they're doing this, because we're looking to increase the stimulation for each repetition to as much as they can possibly tolerate. We want to make sure we see a visible and palpable muscle contraction that continues to increase during the course of treatment. While they're doing this, we want to make sure that they're using their abdominal hollowing maneuver at the same time. And then as soon as they come off this activity, we're going to work them right into their spinal stabilization program as well. And so this is a nice adjunct that you can potentially use. STEM units are around the clinic, and we've been using this for years with these folks who have the, grade 1 and grade 2 spondies, and getting good results with them, getting these folks back to sport. We've even sent some patients home with this type of activity as well early on to help facilitate the erector spinae musculature on a more regular basis at home. We've discussed a clinical-based spinal stabilization program in some detail at several points so far during this lumbar module. I think it's also important to note, though, that there are other exercises that we may have to progress patients to, especially those individuals who have a history of resistance training in their past, or individuals who are looking to get into higher level activities. And so it's important to understand, right, how would we prescribe some rowing type exercises, whether it be bent rowing, lat pull downs, cable rows, etc. We may get individuals who want to do something along the lines of a stiff-legged deadlift, right? We may want to train the glutes and the lumbar extensors with that type of an activity, or perhaps with an isolated lumbar extension type activity on one of the machines that we see commonly at the gym. We may want to train the glutes maybe with a leg press activity, or potentially a lunge activity as well. And so these are activities that we can get patients involved in. We've talked about planking maneuvers already to some extent, but we can talk about additional exercises that can work off of a planking type maneuver that can make the activity more challenging. And so I know for some of you who've been in the gym and you've done these exercises, these are second nature to some of you, but some of you look at these exercises and you're not familiar with them, you haven't been in a gym setting, and that's perfectly fine. In my case, Now with the clinical practice that I typically have, I see patients in the AWC. It's a great place to see patients because I can use the gym. That's there for my patients for a visit or two, no problem. But I do have 2 personal trainers that I typically refer patients to for higher level activity. I just don't have the time clinically to be in the gym, and that's my primary mode of intervention with folks. I may get them in the gym maybe to show them an exercise or 2 they're going to work on their own, but if I'm trying to get patients back to high level activity, there's a couple personal trainers that I'll refer patients to that I know can spend time with them one-on-one and work through that. So I think it's important to understand where your limitations may be when it comes to exercise prescription, return to sport. We many times have to refer to a personal trainer or potentially get a coach involved if we're dealing with an activity we're not familiar with. I would say though that if you haven't been in the gym doing these type of activities, give it a try. Just like all the exercises that we've been describing, you should be familiar with all of them, how to perform them properly, how to progress them, right? And then what substitution patterns we may need to consider that the patient needs to improve upon so they can optimize their form and improve and optimize their own outcome. Additionally, we may have patients who want to return to a running program. And this is just an example, one example of a return to run program. You'll see several. Once you guys go out to your clinics, you're going to see return to run programs that different physicians may prefer, different PTs prefer, and I would say evaluate all of them and use what works best for you. This is an example of one that we've used in the past. The 8 levels for me really refer to almost like an 8-week progression for folks to get back to high level activity, so we take things nice and slow. With respect to level 1 there, before we would start the running, it's assumed that the patient can walk 25 or 30 minutes at a very brisk pace without any problems, right? So they're not getting worse after walking for 30 minutes. In this particular case, we would then start them having them run for 1 minute, walk for 5, and then repeat that cycle 5 times and see how they feel, right? And then do that probably 2 more times that first week. And if there's no problems with that, right, then we increase the running to 2 minutes, right, the walking to 4, and again we repeat that cycle for 5 minutes, so it's about 30 minutes of activity, and so on. Can we skip steps? Absolutely, right? So if you want to go from 2 to 4 minutes of running and you feel the patient can do that, go ahead and do it, but have an understanding as to when you may need to pull the reins back a little bit as well. I put an 8-week program out here, 8 levels, because like I said, it just makes sense to me that 6 or 8 weeks to get patients back to running 20 or 30 minutes is a reasonable expectation. We don't want to move these patients along too quickly, especially folks who have disc pathology or potentially a pars defect. And so this is a reasonable approach to getting patients back, but there are others that are out there, and I think you have to work with the one that you prefer the most and one that fits your patient's needs the best. So in this particular presentation, we started by talking about clinical practice guidelines from the orthopedic section of the APTA and from the American College of Physicians. Both of those guidelines are going to be important to help us provide evidence-based care for our patients with lumbar disorders. We also discussed several different clinical conditions, including how these patients present with these different conditions and then what the management would entail. So what's next? Well, we're certainly going to have to spend some time with patients who have this psychosocial overlay. And so our next lecture and our last lecture for the lumbar spine will deal with individuals who potentially have fear avoidance and how we would potentially manage these individuals. We touched on this a bit when we talked about those practice guidelines from the American College of Physicians, when we started to look at treatments for patients with chronic low back pain that now look at a mind-body connection and are really quite helpful for individuals who have conditions like depression or anxiety or potentially have fear avoidance beliefs associated with their condition. So we'll talk about that condition in our last talk for the lumbar spine and our last talk of the semester. Thank you for your attention, and I hope this was value added for you. Thank you.